Hello everyone and welcome. My name is Barb Cochran and I am the director of the DeTournier Center for Healthy Aging, and I'm also associate director for the Northwest Geriatric Workforce Enhancement Center, which is sponsoring this lecture series, Geriatric Healthcare Series. Today I'm very happy to reintroduce to you Dr. Zachary Marcum. He completed his PhD in Clinical and Translational Science at the University of Pittsburgh Institute for Clinical Research Education. He also holds a PharmD from Butler University in Indianapolis, Indiana. And Dr. Marcum conducts clinical research in the areas of pharmacoepidemiology and health services interventions to measure and improve medication adherence and drug-related problems such as falls for older adults. So we're really lucky to have him here today to talk to us about medication adherence in older adults. Welcome again, Dr. Marcum.
Thank you, Barb. All right. So thank you all. I'm very excited to be talking on this topic today. It is truly my number one passion in what I do, measuring and improving medication adherence in older adults. C. Everett Koop, I think I mentioned this quote if you were here for my last lecture on meds and falls. He's the previous Surgeon General in the U.S. He's famous for his quote when he said that drugs don't work in patients who don't take them. And so that's essentially what we're talking about today. And I want us to keep in mind throughout the entire lecture that medication adherence is a complex health behavior. So there is certainly not a silver bullet that has been discovered, and that I don't think there ever will be, because we're talking about health behaviors, which are very complex, dynamic sorts of things. So these are the three main objectives for today. We're going to talk about risk factors for and the measurement of med non-adherence. Then we'll talk about some health policy initiatives, because with our changing healthcare environment, this is a really, really hot topic. And the reason why a lot of folks care about this is because reimbursement is being tied to it. And then finally, we'll talk about some ways, some interventions that we might employ in the clinical setting, and also some entrepreneurial sort of things that are happening to improve medication adherence. So what is adherence? The World Health Organization defines it as the extent to which a person's behavior, and in our case today, we're talking about medication-taking behavior, so the extent to which that corresponds with agreed recommendations from a healthcare provider. You may have heard this term called compliance in the past, but really we've moved away from that term. It's thought to be a little bit too paternalistic, and now adherence is kind of the new term, really signifying a relationship between the patient and the provider. So you will see all kinds of statistics thrown around in the literature about how common is medication non-adherence in older adults and in adults in general. The most common statistic that you will see is that half of older adults are non-adherent. But it's important to not take these statistics at face value and to really understand what that means. And so I'll get into this in just a little bit. But basically we know that it is a big problem. It's prevalent and it's costly. So it increases the risk of hospitalization. Med non-adherence is what we're talking about, including readmission, which is a really hot topic. It decreases health-related quality of life, and medication non-adherence has been shown to increase the risk of death. A lot of various cost figures are thrown around. The most common one is that it's associated with $100 billion in preventable cost each year in the United States alone. And that is due to these health outcomes that we mentioned, so hospitalization, morbidity, mortality. There was a report a few years ago from the Congressional Budget Office that showed that if we can increase medication adherence by just 1%, we can reduce medical spending by 0.2%. And 0.2% sounds like it's a teeny tiny number, but when you think about the whole medical spending of Medicare, for example, each year, we're talking hundreds of millions of dollars that we could save just by a 1% increase in med adherence. So a meta-analysis that really summarized hundreds of studies that looked at med adherence, it found that adherence is about 80%. And so again, these various figures have a lot of variation because of the way that adherence is defined, assessed, and measured. And that's really an extensive body of literature, and there's tons and tons of ways that this can be assessed. So the first thing to keep in mind is that adherence is a multi-step process. So the first step is that the right prescription is written, and that gets at the idea of appropriate prescribing. And then the patient needs to fill it. This can either be through a community pharmacy or a mail order pharmacy. And then once the patient has the medication, they take it as intended. And then finally, the patient continues to take the prescription. And so this gets at the different kind of subtypes of what we mean when we talk about non-adherence. So non-fulfillment is that first part where the prescription is written and it's filled. And so that is another, in other terms, called primary non-adherence. If the prescription is written but the patient does not pick it up. Non-adherence in general is often just, if the patient's supposed to take it twice a day but they only take it once a day. Non-persistence is over time. So say a patient is supposed to take a statin for over a year's period of time and they stop by month 7. So that's being non-persistent. And then over-adherence is sometimes seen where patients can stockpile medications, or if it's a PRN medication, they can be using more than actually is prescribed. So there's really many different ways that patients can be non-adherent. It's not a single construct. So according to the World Health Organization, they classify 5 different interacting dimensions that can affect medication adherence. So social and economic factors, the biggest one here would be cost. A lot of older adults face cost-related barriers. The healthcare team and system-related factors. You might think of a formulary, for example, as being overly restrictive. Condition-related factors. A lot of conditions that are asymptomatic, like hypertension, lead to non-adherence because the patient is not constantly reminded when they're taking their medicine of why it is that they're taking it. They're trying to prevent cardiovascular outcomes 10 and 20 and 30 years down the road, and that's not as reinforcing as something like an analgesic that relieves the pain in a few hours. Various therapy-related factors, like once-a-day dosing, is obviously easier than 4 times a day dosing. So if you can simplify regimens, that really goes a long way. And then patient-related factors. And we'll talk mostly today about patient-related factors. And it's important to keep in mind that all of these dimensions are interacting. So it becomes extremely complex. This is another conceptual framework that one of my colleagues from Pittsburgh put together, Waleed here. He's an internist. And this is not meant to really get into the nitty-gritty details of all the different arrows, but simply to show that this is complex. And so there are 3 main buckets here. We have patient factors, health system factors, and provider factors, all impacting medication adherence. And so to kind of dive in with the patient factors, we have illness representation, so how the patient views their illness. Is it something that they can be cured from, or is it something that is chronic and lifelong? Cognitive function, which is a really important issue in older adults, and all the different degrees of cognitive function. Demographics, so age, sex, race, coexisting illness, and medication characteristics. So there are literally hundreds of risk factors for medication non-adherence that have been looked at in the literature. And this is just kind of a distilled way to think about them when you're interacting with patients. So now we're going to talk about how adherence is measured. And this is important because it has to do with how you could actually implement this in a clinical setting. So self-report is the most common way that adherence is measured. And that can either be done through interviews or survey instruments. I would say the next most common way is pharmacy claims. And what I mean by that is when a patient goes to a pharmacy to pick up a prescription, the pharmacy submits a claim to the third-party insurer that is basically, it becomes a data field that people can then access. And it simply means that the patient paid and picked up for that prescription. It, of course, does not tell you that the patient took it. So it is more a proxy for access to the medication. But it is used, and we'll talk about this in much more detail, it is used more and more commonly in research and in clinical settings. Other ways that adherence can be measured include electronic monitoring, pill counts. So pill counts if you have a patient coming in, say, and they bring all their medications, you could literally say, pour out the antihypertensive, you know the date they have it filled, you know how they're supposed to take it, say twice a day, so you know how many pills should be left. So it gives you an idea of kind of a real-time count of, are they behind, or are they taking too much, or are they right on track? Drug levels are one way. Unfortunately, not a lot of drugs have levels that we can monitor, and this is, of course, more common in an inpatient setting, but it is one way that you could assess adherence, say, to phenytoin for epilepsy. And then biologic response. And I would say one of the most common conditions for this is antihypertensives. So if you have a patient who their blood pressure is not coming down and you've added more agents and you've added more agents, well, one thing, of course, that should pop to your mind is, are they taking all these new drugs that I've added? And so that's a biologic response, the response of the blood pressure. So there is no gold standard for how to measure adherence. It is recommended to use more than one because you can probably see that they're measuring different constructs. Of course, we don't always have time or resources to do this in a clinical setting, but the more the better really is the take-home message, and something is better than nothing because unfortunately I think a lot of times adherence is not even part of the conversation, or we just kind of chalk up a patient and say, oh yeah, they're not adherent to their meds, but what exactly does that mean for that patient? So I just wanted to point out this is considered the gold standard, and if we go, whoops, looks like the slides went away. Oh, here we go. Okay. If we go back a slide, so electronic monitoring here, I just wanted to point out what that means. It came back, yeah.
Oh, okay.
Something just popped up. So this is typically called MEMS, or Medication Event Monitoring System. And this is a very old image of a computer of what they used to look like. And basically what this is a microprocessor chip that's embedded in the pill cap. And so when the patient opens the top, it records the date and the time that was opened. And again, this is not telling you that the patient actually put the pill in their mouth. So again, we're getting closer than a pharmaceutical claim, for example, but it's still the patient could open it, look at it, and not take it and put the cap back on. You're seeing a lot of these also for inhalers and other different dosage forms. But in clinical trials, this is typically what is done because they want to be able to measure how often the patients enrolled in the clinical trials are using those medications. So this is technically the gold standard. But we're not going to talk about that because that's too expensive really to use in clinical practice, and it's not feasible for a lot of patients. So we're going to talk about what we can actually use. So self-report. Like I mentioned, this is the most commonly used method. It is good because it's simple, inexpensive, and convenient, and it provides information on patterns of actual medication use. And if the patient's telling you, I tend to forget, for example, that's their patient-specific reason for their deviation. It has good specificity for non-adherence, and that's a research term. And so what does that mean? That means that if someone tells you they're not adherent, chances are they're not adherent. They're not typically going to lie about that. And they're moderately related to health outcomes. You'll hear a lot of times that people say that self-report is, people tend to over-report their adherence, and that for the large part is true. But they have been shown, these instruments have been shown to be moderately related to health outcomes. Of course, they're limited in the sense that a lot of patients fall victim to social desirability bias, meaning they want to appear like they're doing what they think you want them to do. And so really, I think it's important anytime you're engaging a patient in conversations about adherence to normalize the behavior. So you can say something like, it's difficult to manage your medications, I understand that, and then get into kind of the screening questionnaire. So I think that can go a long way, normalizing the behavior. Again, cognitive impairment, of course you're not going to administer one of these instruments to someone that is severely cognitively impaired. It has modest sensitivity for non-adherence. So this is kind of the flip side of specificity. So you might miss some people due to this social desirability bias who truly are non-adherent. And like we'll get into in a couple slides, there are tons and tons of instruments, and if you've done any work in psychometric properties, there's a whole literature on how to really show that an instrument is valid, and a lot of these instruments have not been shown to be valid. So this is just an example of a systematic review that looked at 60 different articles, and there were 43 different adherence scales. So holy cow, there's all kinds of stuff out there for us to use. I want to just show a couple examples because you might consider somehow employing these in your clinical practice, either as on an intake or if the patient fills it out in the lobby while they're waiting. So Don Mariski is the author here. He created the Mariski Adherence Scale. The original one was 4 items, and I'll show you that a little bit later. This is a newer one that's 8 items. And he validated it originally in hypertension. And so just kind of walking through some of these items, you can see here, do you sometimes forget? And that is typically the most common barrier that patients report. They simply forget, especially older adults. In the last 2 weeks, was there any day when you did not take your high blood pressure medicine? Have you ever stopped it because you felt worse? And so that gets at the idea of side effects. When you travel, do you sometimes forget? Did you take it yesterday? When you feel your blood pressure is controlled, that gets at the idea that hypertension is typically asymptomatic, and then so on. And so at the end of that, you get a score, and you can kind of rank patients as high, medium, or low likelihood for being non-adherent. This is another example of a scale. This is the Beliefs About Medications questionnaire that was developed by Rob Horn from the UK. And the idea here, that his theory that he has, is that patients have this competing issue between concerns about medications and the feel for necessity of medications. And it kind of is this back and forth, and one of them might win out. And so it's important to look at both concerns and the patient's feeling of necessity for the meds. So some concerns, just in general, having to take a medicine might worry me, long-term effects. A lot of patients are worried about becoming dependent. And then necessity, my health depends on this, my life would be impossible without this. And this is the BMQ specific. So you can see here, this is specifically asking about asthma, and any condition could be inserted there, for example. And then he also has a general one, and this is, again, just kind of getting at general beliefs about medicines. And I think this one is probably really important for older adults who have had the most experience with taking medicines compared to some younger adults. And so a lot of older adults that I've interacted with have really strong opinions about taking medicines all across the board, either really strong positive or really strong negative. And eliciting those up front, I think, can really go a long way. For example, if doctors had more time with patients, they would prescribe fewer medicines. Doctors use too many medicines. And so on. So here you're talking about overuse and general harm. All medicines are poisons. I mean, if you knew that your patient felt that way, you might stop and really have a conversation about what are the goals here, what are we trying to accomplish. Whereas if you didn't know that your patient thought that, and you prescribed the medicine, they might be one of those patients that don't pick it up at the pharmacy. So that's just an example of a scale. So we looked at self-reported adherence in a study that was community dwelling older adults, and this is the Health ABC study. It's older adults from Memphis and Pittsburgh, and they were between the ages of 70 and 79 at entry. And so the years that we looked at were year 10 and 11. So these folks are about 80 to 89, and they have diabetes, coronary heart disease, and hypertension as we selected them for this specific analysis. There were about 900 of them, and we looked at how frequent was non-adherence as reported on the 4-item Mariski and this 2-item cost-related non-adherence. So we're getting at kind of general and then cost. And I won't go into the details of the research methods, but I do want to point out for the Mariski here, so the 4-item, do you ever forget to take your medicine? Are you careless at times? And that word careless has been changed because it's a bit pejorative. So the new one does not include careless. When you feel better, do you sometimes stop? And if you feel worse, do you stop? And then the cost-related items, have you not filled a prescription because it was too expensive? And have you skipped a dose or taken a smaller dose to make it last longer? And so you might look at that and say, oh, I don't know if patients would actually report that. So what did we find? We found that the prevalence of the, according to the Mariski, of any yes on any of those was 40%. And that's actually very consistent with previous studies that have shown about 40 to 50% non-adherence. And again, these are folks with chronic cardiovascular disease, CHD, diabetes, and hypertension. And then cost-related non-adherence was about 8%. So a small but sizable proportion of older adults were reporting non-adherence. And so when you add those two together, I think the rate of about 50% makes sense. We also looked at different correlates, and I won't get into the details of those, but basically people that had more health conditions seemed to report higher rates of non-adherence for the Mariski, and people that said their needs were poorly met by income, that was associated with the cost-related non-adherence. So again, the take-home here is that these are instruments that you could consider using. They're brief, they're inexpensive, and while not every patient will reveal the truth or what's going on with them, you'll catch people that you might otherwise be missing. And so I think when you're evaluating whether or not to use self-reported instruments, I think you should view them as an initial screen. You could consider multiple measures depending on your population that you're caring for. It's important, however, that you have some sort of management program or intervention in place that follows and matches what you're screening for. So for example, if you're screening for cost-related non-adherence, then having some sort of mechanism or resource available to help patients who are having cost-related issues. And as with everything that you're measuring, it's important to understand what it is that you're actually measuring. So if it's pharmacy claims, you know, that's not necessarily medication adherence. It's a proxy for medication non-adherence. So that's the risk factors and measurement, which is about a 50-year body of literature, and we still haven't figured it out. So there's still a lot of room for improvement. Now let's shift gears and talk about some of the health policy perspectives. And so this is important because with healthcare reform, there is an increasing business case for addressing medication non-adherence as our payment and delivery system models evolve and place providers really at risk for longitudinal outcomes and downstream costs. And what I'm talking about here are things like accountable care organizations, bundled payments, all these sorts of changes that are happening in our healthcare system. And med-adherence is front and center to all of this. So this is one example of a partnership that was developed between all these different organizations. And you can see here representation from the pharmaceutical industry, academia, and some other agencies. And really, their focus here is to bring together leading patient, provider, and healthcare industry leaders to develop public policies to improve medication adherence. And this is just one example. There are a few others in our country that are doing essentially the same thing. And so med-adherence, like I mentioned, the body of literature is decades old. It's now becoming on people's front and center radar because of the healthcare reform and the policy implications. So you've probably heard of the Star Rating for CMS, Center for Medicare and Medicaid. And that is one of the most popular and common quality measures. And so pharmacy claims are the measure of med adherence that are used for this rating system. I'll talk about the PDC in just a bit, but it stands for the proportion of days covered. That is the measure that is used for the CMS 5-star quality rating system. And basically what this means is that for Medicare Advantage health plans to get 5 stars, which is the goal, you can get 1, 2, 3, 4, or 5, so 5 is the best. In order for them to get all 5 stars and to, in essence, get their 100% of their financial incentives, they need to have more than 75% of their covered beneficiaries with at least 80% of their medication prescribed to them. So the adherence goal here is 80%. Trying to get the arrow. Here we go. So 80% is our adherence goal, and Of course, you can't get everybody to that, but the target is to get 75% of your population to 80%. And the three classes that they started on were oral diabetes, statin, and antihypertensives. And I think it's safe to assume that more medication classes will be coming in the future, but these were the three classes that they started with. So there are other ways to measure med adherence and pharmacy claims that I've listed, but the one that has really been focused on in the quality measures is the PDC, or the proportion of days covered. And it's really simple. It's the proportion of days in the period covered by prescription claims for the same medication or another in its therapeutic category. So for example, say in a 100-day period of time, the patient has a 90-day supply that has been dispensed. So that would be 90 over 100, so their PDC would be 0.9 or 90%. And they would essentially meet the threshold of 80%, for which CMS has determined is important. Now, as a researcher, we are actively looking at this idea that, so why 80% for all classes for all patients? That makes pretty little sense. Can you achieve the same outcome, say, with 75% or with 60%? Or do you truly need 95%? We don't know. 80% is this number that has kind of been perpetuated in the literature from a study a long time ago with a few hundred people in the setting of hypertension. And it's really kind of gotten a life of itself, and now it's in health policy. And so we're looking at that to try to define in different disease states what is the appropriate threshold. So what are the strengths of pharmacy claims? They're objective, they're inexpensive. We can get 1 million Medicare beneficiaries data for relatively inexpensive amounts of money. You can get large samples. You can really do population level analyses. These data are readily available in systems like the VA and in HMOs, for example, like Kaiser. You're free from social desirability as compared to the self-report instruments. But there is wide variability in definitions used in the literature. When older adults are hopping around to different care settings, say for example a hospitalization, you have to account for that, and the quality measures need to account for that as well. And so there are several assumptions. You're going to miss over-the-counter medications. Pharmacies do not submit claims for OTC meds. If you've worked in a pharmacy, you understand that because people can buy OTC meds up front. They don't necessarily need to go to the pharmacy. A lot of drugs now are available as $4 generic fills, and those are simply sold as cash. They're not submitted through insurance claims. And so that's becoming a problem, although it is great for access to care. And again, filling prescriptions does not equal ingesting the medication. So I just wanted to show you an example of a study that we did a couple years ago using the PDC and including these medication classes that are included to give you an idea of the rates of non-adherence in the Medicare population. So I was interested in people that use multiple pharmacies because I saw a lot of that in my training. I used to work at Target and Walgreens in the community, and a lot of those pharmacies put out coupons for new and transfer prescriptions to try to get people to come to their pharmacy. And so, for example, you can get a $20 gift card to Target if you transfer your prescription there, which is great for people to get gift cards, but it's terrible in terms of disjointing care. And you never know what the true medication list is. So you have people just hopping around all over. And so I wanted to look at that in Medicare Part D. And so we had about 1 million beneficiaries who were 65 plus, and this is fee-for-service Medicare. And we looked at multiple pharmacy use, and we used the same exact threshold as the health policy. And this is the take-home slide here. I'll just kind of walk you through this. So the y-axis here is medication non-adherence. So keep that in mind. It's the percent that are non-adherent, meaning they dipped below 80%. So just looking across the board, without even getting into all the details, these are really high rates of non-adherence. So you have anywhere from 25 up to 45% of Medicare beneficiaries being non-adherent. Down here are the medication classes. So we have beta blockers, basically ACE inhibitors and ARBs, calcium channel blockers, sulfonylureas, metformin. the TZDs, like pioglitazone and rosiglitazone, the newer diabetes drugs, the DPP-4 inhibitors like sitagliptin, and then statins. And so I want you to appreciate the rates of non-adherence, and also the fact that this was collected with pharmacy claims data, which is becoming more and more involved in clinical care. You may have already seen this, but in the near future, you definitely will, where you're seeing a patient and you can actually view their PDC. And so a lot of data enterprises are being developed to provide that real-time information for the provider, which is really helpful. You can see if your patients are actually filling their prescriptions. And not surprisingly, we found that single pharmacy use had the lowest rates of non-adherence compared to either group of multiple pharmacy use, which we defined as concurrent and sequential, like using multiple pharmacies at the same time or in non-overlapping periods. So we found statistically significant associations. So basically, single pharmacy use was found to be the best for adherence, which makes a lot of sense. So just to kind of reiterate, Medicare Star Ratings are front and center. They're not going away. If anything, they will grow and incorporate more and more medication classes. And this is all in line with CMS expanding its value-based purchasing. So Part C is Medi Advantage, and then Part D, we're talking about prescription drug plans. And so why are they doing this? So there's three main reasons, as I see it, that they're doing this. One is consumer choice, and I'll show you a couple slides of the plan finder where patients, older adults, can look and see which plans they want to enroll in. So it's really transparency. Also for regulatory oversight. So if a plan is really struggling for multiple years in a row, something can be done about it. And then payment modifications, which is probably the strongest incentive for clinicians because dollars are being tied to this. So this is a screenshot of a couple prescription drug plans. So up here we have prescription drug plans, we have the plan, and we have right here an overall star rating. And I know it's probably a little bit hard to see, but I just want to point out that this is totally searchable by patients. You could just Google plan finder and you could look up this information based on your location. So this plan in particular had 3.5 out of 5 stars, and that is an overall rating. And to focus on what I'm talking about today, which is med adherence, you get down here taking diabetes meds, taking blood pressure meds, and taking cholesterol meds. And this plan in particular had 2, 3, and 3 stars out of 5. So they're not doing the best, but they're not doing the worst. And so an older adult could view all of this and figure out what's important to them and then enroll or not enroll based on that information. So now let's shift gears and talk about strategies to improve medication adherence. Again, this is a really exhaustive body of literature. I would say the take-home message before we get into it, just so you can kind of keep this in mind, is that typically multimodal interventions, including many different components, are going to be the most effective that are patient-centered. So that's kind of the essence of the literature right now. And this is really, I think, inspiring to me. It kind of encourages me to try to figure this out. The World Health Organization is quoted as saying, increasing the effectiveness of adherence interventions could have a far greater impact on the health of the population than any improvement in specific medical treatments. So if we can just get people to take the medicines that are already approved and already available, that for which evidence exists, we could have a far greater impact than maybe approving the next ACE inhibitor. So that's the World Health Organization's stance on this. So when we're talking about interventions, these are the main kinds that we're talking about. So behavioral. So oftentimes you'll have nurses who are administering these. This does not always have to be the primary care provider. This, again, we're in an era of team medicine. Social work, pharmacists, nurse practitioners, PAs, physicians. It's really based on the resources that are available and the training that is available to those clinicians. Monitoring and feedback is a big one. With all the technology that's available these days, there's a lot of cool monitoring that can happen, and I'll talk about some of that in a few slides. Multi-session information. So education has been shown to be necessary but not sufficient to make a difference. So what I mean by that is you probably want to include some sort of education, but it's not going to be enough. It's important to always be there, but you need to do a little bit more than just education alone. And then, like I mentioned, the most effective is going to be a combined and patient-centered approach. So how can we improve medication adherence? This was a paper we wrote a few years ago, just kind of putting some thoughts behind this. The first step is to look for it in a systematic manner. And I think if you take a look at clinical practice, like I mentioned earlier, a lot of this is just simply not being elicited and or documented. And there are many reasons for that. Of course, there's time pressures, resource limitations, but really that was our take-home message, is that we need to look for it first. And the analogy that we made is to treat it like a differential diagnosis. And so for undetected and undertreated problems, such as non-adherence, one way is to conduct screening. We know that providers are not really good at looking at a patient and trying to predict if they're going to be adherent or non-adherent. So I think we need to recognize our own limitations and try to avoid putting labels on patients and to treat every patient the same and really systematically screen for it. And then we also need to have adequate resolutions on the back end to target for patients. So the essence of what we're talking about in this paper is that we need to pay attention to the underlying behavior at hand. And I just wanted to walk through a couple patient scenarios that highlight what we call different phenotypes that really show the differences in the underlying behavior and then how that underlying behavior can be paired with a potential intervention. And this is all on the patient level. If you are a healthcare administrator at some point, either now or in the future, your interventions are going to look way different. You're going to be talking about things like formulary management and cost containment and all these sorts of things, making co-payments free, for example. But today we're talking about patient-level screening and interventions. And so we came up with 6 different phenotypes. I'm sure you guys could come up with more based on your clinical experience, but these are the patient phenotypes that we came up with. So a patient may not understand the relevance of medication adherence to their health. The patient might conclude that the benefits of taking the med does not outweigh the costs, or their information processing capacity is simply exceeded by the medication management regimen. And you see this a lot in older adults who might be frail and suffer from chronic comorbid conditions, who are on 15 medications, some PRN, some scheduled, some once a month, some twice a day. I mean, it's just way too much information. Some patients are not vigilant. Patient might have inaccurate, irrational, or conflicting beliefs with the provider about medications. And the patient could perceive that this medicine doesn't have an effect for them. And so what we did was pretty simple. We just put those phenotypes up here and showed that there are validated instruments, self-reported instruments, that can be used to elicit these underlying behaviors, these phenotypes. And of course, it's not feasible to administer all these different instruments. There are other things that you need to do in a clinic visit. But the goal is to start somewhere. And this is based on the population that you're caring for. So if you are seeing, a lot of really complex patients, you might consider using the Medicog, for example, which I didn't talk about today, but it basically screens for cognitive sort of issues, and if a patient can successfully put together kind of a mock Pillbox. So it's based on the population you're caring for and the resources that are available to you. This is one example of the adherence estimator, and on this last side here you'll see the adherence estimator listed, so it's good for these 2 underlying behaviors. So this is one that I like, and the reason I like it is that it's simple. It's only 3 items, and in my experience, it really captures three of the biggest barriers. The patient is asked at initiation of medication therapy. So this is for a new drug start. So say you want to start a patient on a new bisphosphonate for osteoporosis. You could ask them these three questions up front to really prevent a lot of downstream bad consequences, I think. So I'm convinced of the importance, and they agree. It's kind of a Likert scale. I worry that the medicine will do me more harm than good. If that comes up, you could address some of their concerns. And out-of-pocket cost, so cost here. So if you do that up front, I think it can really save you a lot of time in the long run. And this is interestingly developed by Merck. I don't work for Merck, but it's interesting. The pharmaceutical companies are really putting a lot of investment in medication adherence in general. And they're putting out a lot of really good educational tools and instruments like this one. This is not drug specific at all. You could use this for any medication. This is another platform that the adherence estimator lives on. So this is a website, so a patient could actually fill this out on a computer. So I worry they could just pull down and select. I'm convinced of the importance, pull down and select, and then submit. And it'll give them a summary score. And then there are tons and tons of resources that are available on this page for essentially conversations. They give you language to use for each of these three potential barriers. So, and they've vetted them through qualitative research. And so I really, really like this instrument. If you have the time to do it when you're starting a new drug, I think it can go a long way. Of course, detecting non-adherence does not equate with overcoming it. So that's just the first step. And so let's talk about some of the phenotypes and potential solutions that you could use. So the first one, to remind you, was establishing relevance of the behavior. So in this scenario, we have a 71-year-old male with high blood pressure for a long time. He comes to the clinic, his blood pressure is elevated, and he has proteinuria, so evidence of some end organ damage. He reports that he does not take his blood pressure medicines because he's more concerned about taking chemicals than he is his blood pressure, which to him does not seem unusually high. So what do we do? So one solution is, if you kind of elicit this through your screening, one solution is to use motivational interviewing. There is a very strong body of literature to support motivational interviewing and its efficacy in many different health outcomes. So what is MI, as it's abbreviated? It's a client-centered directive style for enhancing intrinsic motivation to change by exploring and resolving ambivalence. And again, this does not have to be the PCP. People can be trained on how to do motivational interviewing. So again, if resources are a limitation, time is always a constraint. Training other folks in the clinic to do this could really go a long way. And it really draws motivation from the patient rather than the healthcare professional putting it on the patient. And so this figure here just kind of shows the overall goal of motivational interviewing. So you have people that are working against change, so they're not really motivated to change. And then your goal is to slowly but surely work toward change. And you do that over a long period of time and in very small increments. So a second scenario, we're going to go through 4 of these. We're not going to go through all 6, but just to give you a flavor for how you can sort of use this clinically. So evaluating the risks and benefits of the treatment. So we have a 67-year-old female who visits her PCP, and her diagnosis is type 2 diabetes. The patient receives simvastatin 40 milligrams at bedtime, and the nurse instructs the patient to pick up the prescription at the pharmacy. There's no other counseling or discussion. After a week of taking the medication, she begins to notice muscle cramping in her legs and decides to stop taking the simvastatin because the side effect is very annoying. But she does not let the PCP know. So what could we have done differently? Making sure that the patient has considered all of the risks and benefits, as well as how they would feel about the long-term consequences, is really important in this case. And you've probably heard a lot about shared decision-making. It's kind of a new buzzword. A lot of what shared decision-making is involves decision aids. So for example, in this case, there could have been a conversation with a patient about, okay, so people that start on this statin, X% of them might develop muscle cramping. Most of it is minor, and it will typically go away. Some people, have more serious muscle cramping, and if this happens, if your urine changes color, make sure that you contact the doctor or go to the emergency department. But really spelling out the numbers for the patient. So X% can experience this side effect. However, taking it for this number of years can prevent will prevent a heart attack in X% of patients. So it's this trade-off and this conversation between benefits and risk. And there are quite a few decision aids that are available for this and many other healthcare decisions. Decision aids are most notorious for their use in cancer, kind of the decision between radiation, chemo, and no treatment. But you're seeing more and more of this being developed for chronic management of diseases like atrial fibrillation, so anticoagulation, and the risk of bleeding versus stroke and that sort of thing. So this conversation could have been had, and the patient, could have been informed about the potential side effect, and rather than just stopping it and not telling, they could have done something about it. So scenario 3, processing of complex information. So we have an 83-year-old female with multiple chronic conditions, including diabetes, iron deficiency anemia, and GERD. She's taking metformin, glipizide, iron, omeprazole, and they all have different parameters. So all of these directions are very confusing to the patient. So she just puts them in her hand and throws them back once a day with breakfast. So what could we have done to ease the complexity of that information? So simplifying the dosing regimen. The metformin likely was being dosed twice a day. So we could consider switching to extended release once a day. We could also assess medication appropriateness, which of course should always be done. So is the PPI, the omeprazole, really needed? We could do a trial of stopping it to see if the patient really needs it. And then iron, check iron studies to see if the patient even needs iron supplementation. So these are all just ideas to try to simplify the regimen. A pillbox for this patient could really go a long way, into only 4 dosing times, so the patient can see rather than being overwhelmed. Also, counseling should occur about which meds can be taken together and what is an allowable window. I remember a lot of patients really became overwhelmed when a lot of the kind of hypervigilant patients who really take the instructions literally, if you tell someone to take it every 4 hours, they're waking up in the middle of the night to take it. Well, most times that's not necessary, but patients don't necessarily know that, and they need to be told that. So really providing good counseling that fits within the patient's daily life can go a long way. And so the overall goal here is better organization of and communication about the regimen. And so the last example is a patient who kind of fell off in terms of remaining vigilant. So this is a 66-year-old male with diabetes. He's a business executive, and he's in a very fast-paced environment. He's been taking his metformin for about 10 months, and at first he was on top of it 100%, but recently he realized that he sometimes forgets amid his busy schedule. So for this patient, queuing, which is typically one of the most common interventions we use, could really work for this patient. So we can use different things like alerts or reminders. In the era of smartphones and apps, there are dozens and dozens of options. And it also helps patients keep track of when they've already taken it. That's another common thing is you can't remember if you took it earlier in the day or was that yesterday. Well, if you have it tracked or logged, you won't have to exert so much cognitive effort toward that. And so, yeah, there's all kinds of gizmos and gadgets that are available for this. So just to summarize about this idea of phenotypes, a lot of people, I think the current state of affairs is that we simply say this patient is non-adherent. And I think it's time to move beyond that and to really look at the patient and their specific barriers to make the biggest impact. So a blanket intervention like a Pillbox would not work for all of them. In fact, we just found one of the 4 for which a Pillbox would be appropriate. But most often we say, oh yeah, give them a Pillbox, that should work. And even giving someone a Pillbox sometimes is not enough. You need to show them how to use it. So without a correct, quote, differential diagnosis, we're not going to achieve the benefit that we want. And even worse, patients could be harmed and resources could be wasted. So that's, in essence, what we were getting at with that whole thing. And so now I'll just finish up in the next couple minutes by talking about some of the entrepreneurial efforts that you're seeing. If any of you are interested in really diving into medication adherence and making it part of your professional and personal ambitions, I just want to provide a couple examples of companies that have been started to improve medication adherence. And so this is Health Prize. Their whole shtick is that they use gaming, so the idea of quizzes and games to get points. There's a whole body of psychology literature and behavioral economics behind that, and they are growing rapidly. A lot of companies use them because obviously companies care about health costs, and so they'll use Health Prize to improve adherence for their employees. There are financial incentives, raffles, all that sort of thing, sweepstakes. And so their whole kind of tagline is they want to make medication taking fun, because obviously for some patients it's not fun. So that's one example. And then there is intense effort to develop predictive screens to better identify at-risk patients. For example, this company, RxAnti, they have their own proprietary algorithm to find patients, say in a health system that might be at risk, and then they tailor their interventions based on those patients' risk factors. And so if you're at all interested in kind of machine learning or algorithm development or personalized medication interventions, this is a company that you could read more about. They are also growing rapidly. And so I think the point here is that there are many, many angles that folks are trying to take to make an improvement in medication adherence, both in the private sector and in the health sector. And then finally, this is an example of a Pillbox that is smart, I guess you could call it, because it's you plug it in and it would actually light up when that specific slot is due. And it would keep track of whether or not you opened it. And that data could be fed back, say, to a caregiver who might be able to then intervene if it's not opened in the morning. So they could call their mother or father and say, hey, what's going on? Why didn't you take your morning pills? And there are many, many different iterations of this. Of course, these can be costly, and a lot of insurance carriers do not cover them quite yet. This is an example of an app. And you might say, well, older adults probably aren't using apps, right? Well, some of them are now, and even more will be in the next 10 and 20 years. And so this is the new normal, I would say. Vitality is an example of a cap that actually lights up when it's time for your medication to be taken, and it will also make a sound, kind of a song noise, like a cell phone ring. So it's both lighting up and making noise. And then when you take it off, it keeps track of that. So there are numerous examples of ways to queue and to keep track and to log medication adherence. But just to kind of bring us full circle about what I mentioned in the beginning, oftentimes the most successful interventions are going to be those that are multimodal, so using more than one of these, and patient-centered, personalized. So this could include education plus, say, a Pillbox like this, education plus motivational interviewing, educational plus queuing, so that sort of thing. So that is what I have for today. At this point, I'm happy to open it up for questions or comments or insights from what you have found to be effective and useful.
So I'll read the questions on the chat, and if people in the room have questions, if you could repeat them so it gets into the recording. Are there questions in the room?
Working out in the homes, I see most often it's that the patients don't really understand how to take it. They're really interested, and it seemed like a lot of the tools that you use were self-reported, so they report that they're taking their medicine as prescribed, but really they aren't. Is there a tool for that to measure their?
Yeah, that's a great question. So the question was, a lot of the self-reported measures don't really test the patient's ability to do their actual regimen and to execute it. Is that correct? And so
But they don't even understand how they're supposed to take it.
Right. Yeah, so that's a great question. So there are a couple instruments.
That's okay, go ahead.
Okay. There are a couple instruments that basically challenge someone to complete. So that would give them a mock regimen, and it will say basically put where you would put the pills in a pillbox. So that's one example to kind of get at that cognitive executive function. If they can do that, you could also just, with their own regimen, say, show me what you do. Fill your pillbox for me. And then you watch them, and you can correct based on any mistakes that they're making. So for their specific regimen, I think the best thing to do, if you're in their home already, that's the perfect, you look at how they're storing their meds, if there's anything to fix there. And then you watch them fill or use their current system. You just observe them in their, that's actually the best thing to do, is observe them in their home environment. So you have the luxury of that compared to in the clinical setting, they're out of their natural environment and they're now in your environment, which is not always the most useful.
So Peninsula College is asking, in assessing adherence, is it reasonable to focus on one medical condition with measurable outcomes, like type 2 diabetes, in a patient with multiple conditions? Can adherence in one condition extrapolate to overall adherence?
That's a great question and extremely relevant for older adults. I don't know if there's a clear-cut answer for this. So I think the best thing to do is to understand a patient's general beliefs about taking a medication, which could extrapolate to all of their conditions. But I think you have to start somewhere, and I think you need to really focus on, say, for example, type 2 diabetes. I think you just need to focus and assess their adherence for the specific condition. But I think it's helpful if you screen for their overall beliefs for these other conditions you mentioned, hypertension, osteoporosis, pain. If you know that they are worried about addiction, then that's really useful information when you're treating their pain. But I do think that there is a lot of value in focusing on one condition at a time.
Can you give examples of apps used for queuing or med adherence?
Yeah. Gosh, I'm going to draw a blank on the names. But if you go to the iTunes store and you type in adherence, you'll find a few. There is also an article that summarizes current med adherence apps. I don't know if I can send it to Barb and then she can then forward. Yeah, so I can send this article from, it's the Journal of the American Pharmacist Association, that basically summarizes the current apps that are available. And that'll do a much better job than my memory. And there's more and more every day. Some of them are free, some of them cost a couple dollars. Some have free versions and then the expanded version costs. So
Some type of going on.
So we see many patients struggle with setting up their pill boxes largely due to their refill schedules. For example, they just picked up their refill of one med, but one is going to run out midweek, but the refill isn't available yet. Any advice or strategies to help with this?
Another very excellent question. So this gets at the whole idea of medication synchronization, which is obviously an issue. When I mentioned using multiple pharmacies before, sometimes using the same pharmacy but having to come multiple times within a month is problematic. And so you're starting to see a lot of community pharmacies and retail pharmacies implementing these medication synchronization programs to solve this problem. So I would say that we're getting much better at it. I think if you have a patient for which they're reporting that this is an issue, that you offer to call the community pharmacy and see if what you would want to ask is, do you have a medication synchronization program in place? A lot of them do. And so, unfortunately, I mean, you can understand the reason for a lot of this comes down to insurance. And sometimes if the refill is too soon, they can't fill it. But like I mentioned, there are pharmacies that are doing this very well. So I would say engage with your community pharmacy. That's a great question.
And a huge issue.
Huge issue, yes, huge. Transportation is a huge issue for adults, especially for older adults, and for their caregivers who, are living busy lives themselves. Even saving one trip to the pharmacy can go a long way. Looks like there's another one.
Is there any data that looks at quality of life in older adults who are adherent versus non-adherent for medications with significant side effects, such as increasing fall risk or weight gain? And do you have any advice for providers in addressing these quality of life issues instead of simply weighing them against the consequences of non-adherence, even bisphosphonates?
Quality of life. Let's see if I'm understanding this. Quality of life in older adults who are adherent versus non-adherent. Oh, I see. Okay, so yeah, so the medication class that comes to mind is actually chemotherapy or oral oncology, which the main problem with adherence in that area is side effects. And so yes, this is a big deal. The quality of life is certainly going to be less in patients that are experiencing side effects. And so I think having the resources and the medication kind of management lifeline, or someone that they can call when they do experience these side effects, is really important. You certainly don't want somebody to adhere to a medication that's causing side effects that are hurting their quality of life. And oftentimes patients are the smartest, and you'll hear this term called intentional or intelligent non-adherence, meaning the patient knows best. They're not feeling well, so they stop. That's okay. The connection needs to be made, though, that they know to communicate that with the healthcare provider and the healthcare team. And so I think having that communication and that lifeline in place can go a long way. So I think, do you have an advice for providers in addressing these quality of life issues? I think educating as much as possible about which side effects to expect, what they might look like, what they might feel like, and empowering the patient with a plan of, if X happens, then do Y. I think that can go a long way.
So Missoula is asking if you can talk a bit more about deprescribing in frail older adults on mini-meds and poor medication adherence.
That's an excellent question. So deprescribing is a very, very hot topic right now in geriatrics. So some of the classes that I would consider, so when we're talking frail older adults, I'm thinking kind of end of life sort of things. And so, for example, statins. We know that statins take years to prevent the negative cardiovascular outcomes that we're trying to prevent. So if your patient that you're caring for does not have years to live, if their life expectancy is maybe, say, less than a year, you might consider certain classes like statins as agents to consider discontinuing. Now, in other patients, I think you start eliciting goals of care. So for diabetes treatment, you might let the A1C go up a little bit higher, 8%. Blood pressure control, you might allow the goals to be relaxed a little bit. And so even if you're not stopping medications, you might be coming down on doses. So really, I would say a lot of this has to do with the goals of care for the patient and also their life expectancy. But this is a very actively researched area in terms of deprescribing. Yeah.
Do you have any tips? This is really a big challenge in hospice. There's some scheduled medications, and obviously the Pillbox is good unless we're titrating a lot. But like that and the PRNs, like any tips for trying to deal with that whole added confusion for the patients?
Yeah, so the question was, in hospice care in particular, I guess simplifying or doing better at managing a lot of scheduled and PRN medications.
Yeah, the mix between the two, it gets really confusing.
Right, yeah, so I would say within the PRNs, trying to align the dosing as closely as possible. So, for example, if something is Q4 or Q6, the issue becomes when everything is not aligned. And this is kind of like the med synchronization thing, when the refills aren't aligned. So as much as possible, trying to align the timing of the dosing. And then also, I think, really looking at what the patient's using and kind of peeling off stuff that they're not even using. Because I think we have a lot of just residual stuff that is just kind of hanging on there just in case, that causes a lot of confusion. So if the patient hasn't used it, in the past week or so, or the past 2 weeks, that might be something to consider getting rid of.
Do you have a good log sheet that you recommend? Any kind of like public domain log sheets that you recommend?
So the question was about having a good log sheet, like a public domain log sheet. There are certainly medication logs, and I can send out a couple. I would say this is probably going to come down to your healthcare system about what they use. Like, you don't have anything? Oh, okay. Yeah, so I can certainly send some examples. But like in the nursing home, for example, they have their entire MAR that they document on that it keeps track of all the PRNs and the scheduled and that sort of thing. But I can send examples of medication logs. Yep.
So Anchorage is asking about the Medicare Star Rating. An interesting question. Why would the patient care about the adherence rating of a plan?
That's a great question. So the patient would care about they would probably less care about the rating of the plan and more with the outcomes that are associated with improved adherence. And so, for example, these classes we're talking about statins, antihypertensives, and oral hypoglycemics, there is strong evidence to show that better adherence is improved with better outcomes. And so for the patient, they're probably never even aware of the star ratings unless they're really savvy or they work in healthcare. But I would say they're more incentivized by the beneficial health outcomes that could be achieved.
Can I ask a question?
Yeah.
Has it been around long enough to see potential effects on the cost to the patient of the plan?
Yes, so that's another important, so are you talking about
The financial incentives
Yeah,
that go
so-
to the plan?
Yep, so some plans, so every plan is going to have a different premium. And so if a patient signs up for a plan that has lower star ratings, chances are their premiums are going to be higher because they're being dinged by Medicare, for example. So these 5-star plans are then going to get more beneficiaries enrolled because they have the higher quality and they're able to offer lower premiums. Is that what you're getting at? Yeah.
And maybe cover more meds?
Cover more meds, yep. So it's this trickle-down effect, I guess. They're trying to raise the bar for everyone and weed out the plans that are not doing very well.
Other questions, folks? Okay, thank you very much.
All right, thank you.